So why don't we go through the various treatment in terms of, let's start with various stages. So let's say for stage 4 disease, right?
Right.
Someone coming to you, let's say with a metastatic disease, and you've seen it on the imaging study. Can you walk us through like what is your approach in consulting that patient, and what do you talk to them about? How do you talk to them about their disease?
So the first step is, of course, to determine the extent of disease. Where is the tumor? Where is the melanoma spread to? Because it changes a little bit about how you would treat those patients. But in general, our first line of treatment is immunotherapy, one of a checkpoint inhibitor. Whether we use anti-PD-1 alone, or we use anti-PD-1 in combination with anti-CTLA-4, or now there's a new antibody, relatlimab, anti-LAG3. We can get into the weeds on that. There's a lot of
I
detail.
think we should. That's why I'm really excited about tap into like your expertise.
So okay, so checkpoint inhibitor is what I would talk to the patient about first, and our most active drug is an anti-PD-1 drug, either nivolumab or pembrolizumab. They're pretty equivalent. And in some patients, I prefer to treat just with those single drugs. Patients who have lung-only disease, I kind of think that there's not a lot of advantage to giving combination. Also, patients in whom you think you're worried about side effects, which we can talk about as well. But there is an increased response rate, increased a little bit better progression-free survival in patients treated with combination. The combination, of course, that we have the most experience with is with nivolumab plus ipilimumab. And I would say that combination is what I would rely on in patients with liver metastases, bone metastases, brain metastases for sure. The side effects are more frequent with the combination, of course.
Yeah.
But there is, I think, an advantage in terms of outcomes for in these situations where there's metastatic disease in these other sites of these organ sites. Recently, there's a randomized trial comparing nivolumab versus nivolumab plus relatlimab. It's an anti-LAG3. We know that the LAG3 antibody by itself was not terribly effective, but when they added to nivolumab, the progression-free survival was a little better. Whether they have not reported the response rate, I suspect that the complete responses were not that much different. And I've been personally a little hesitant because the toxicity is more with the relatlimab. So nivo-relatlimab is definitely an option. I'm still been a little hesitant about it. I'm not sure exactly where it fits right now.
The hesitancy is due to because you have a lot more experience with the Nivo plus Urave combination.
There's that plus the data for the Nivo-Rela. What we're looking for really, what I'm looking for is our complete responses. Those are the patients that we can potentially cure, or either complete responses or really deep responses. Those data, the response data, hasn't really been reported yet with the Nivo-Rela. So I don't know if there's whether Nivo-Rela is more likely to cure patients.
Maybe we should